Good evening, everyone. A warm welcome to the BMC Oncology Webinar Series 2025, hosted by BALCO Medical Center, Naya Raipur. The theme for today's session is Changing Paradigms in Colorectal Cancer Management, supported by CIPLA. Our esteemed chairpersons for today's session are Dr. Bhavna Sirohi, Senior Medical Oncologist and the Medical Director of BALCO Medical Center, Naya Raipur, and Dr. Dipanjan Biswas, Consultant, Surgical Oncology at BALCO Medical Center. Our first session for today is on management of MCRC post-progression on cetuximab. The session will be led by Dr. Deva Dulal Biswal, Senior Medical Oncologist at BALCO Medical Center. Over to you, sir.
I think good evening, everyone. I think this is a great topic, very pivotal, especially with molecular oncology. Dr. Deba is traveling. So I think Dr. Yashwant, you will be able to take this session?
Yes, ma'am.
Okay, thank you so much. Thank you. Thank you.
Thank you so much, Dr. Yashwant. Requesting you to present the slides.
Yes. Good evening, everyone. Thank you. Thank you, CIPLA Oncology, for and as a man for organizing this. So today I will talk about the management of metastatic RCC in CRC post progression on cetuximab. Is my slides visible? They are full screen.
Yes, sir, they are.
And I hope I am. So today I will discuss about the management of metastatic colorectal cancer, which has progressed on cetuximab. After this, we will discuss in panel discussion about the management of colorectal cancer. To begin with, we will discuss in a detail in panel discussion. So I will go slightly fast because many of topics are already I will be talking. Achal, is my slides moving or not? Okay.
Yes, sir,
so
they're moving.
Moving, na? So
Yes, sir.
We will discuss about the various genomic alterations which are present in metastatic CRC, like RAS mutation, then a non-RAS mutant patient with BRAF mutation, then MSI, whole fusions, then NTRK fusion, and NTRK, then regarding HER2. So all this we will talk. Then, as per NCCN guidelines, there are 4 recommended regimes like FOLFOX, CAPOX, FOLFIRINOX, which we will discuss in panel discussion in detail. And FOLFOX and FOLFIRI, they are backbone of chemotherapy for colorectal cancers. So whenever this also we will discuss in panel discussion that we prefer NGS for all of our patients with various IHC testing for BRAF. Then we do MSI regularly, then HER2, NTRK, and all the available mutations. Then there will be some role of liquid biopsy. Regarding liquid biopsy, it is minimally invasive and time is very less. So it is also a good option for our most of our patients. Then what are biomarkers which we do? We do for every patient's MMR, MSI testing, and metastatic patient we do RAS, RAF, HER2, and NTRK mutation analysis. What are the prevalences? Only 26% patients are wild type. So majority they have other targetable mutation. This should be kept in mind. Then these are the various pathway through this colon cancer and this cancer proliferate. So there are VGF, EGFR, HER2, NTRK, then which there are various molecules which affect the RAS, RAF, MEK pathways and PIK3, AKT, mTOR pathways also. So what are the various biomarker we do? MSI rates are 4 to 7% in metastatic CRC. KRAS mutation prevalence is 36 to 40%. NRAS is 4%. BRAF B600E is 5 to 12%, and which is very high. And till now we were doublet therapy we are giving for left-sided RAS wild type patients. Then HER2, it comprises 4 to 7%. Then KRAS, which is a traded mutation, it comprises 2 to 4%. NTRK less than 1, RET less than 1. And other biomarkers like POL and POL D1, they are, and TMB is also an important marker for guiding immunotherapy. So what are the basic backbones? Like for patient with MSI, MSI low or stable, the usual Capox or Folfox or Folfiri, they are backbone. For very fit patient, we give Folfirinox. And for MSI high patient, our preference is immunotherapy if they are eligible or there is affordability. Recently, I had one cardiac transplant patient. He was MSI high, but due to fear of rejection of cardiac transplant, we were not able to give him immunotherapy. So this is also a scenario. So then there comes what is sequencing, that how we can use the various drug. If patient has not received earlier irinotecan, then we can give irinotecan in second line. Then if no prior immunotherapy, then immunotherapy we can give. So there is a range of options. So what are the various options in VGF inhibition with bevacizumab? So, like we will discuss in panel discussion, that neoadjuvant bevacizumab should not be used for neoadjuvant patient in resectable metastatic CRC patient, because this will not lead to control it. Uh, this has not shown benefit. Then first line bevacizumab is added for patient in unresectable case only, and maintenance bevacizumab also has data. Second line bevacizumab, even after progression has done good. And GI perforation is very rare, but it is a better potentially fatal combination of bevacizumab. Then comes the various rare mutations which we are very significant, like KRAS mutations. Now with data of breakwater trial of recent ESCO, we have a option of even sotorasib with EGFR inhibitor in first line also, but this option is there in second line also. Then in first line left-sided tumor, we generally give in patient with KRAS wild type only, we offer cetuximab or panitumab. Otherwise, the ideal drug is bevacizumab. In a BRAF patient, it is encorafenib or cetuximab is an option, but we generally don't use EGFR inhibitor alone. We don't use for such patients. And also cetuximab and panitumab, they have infusion reaction of 1 to 3%, which are many a time dreaded to manage in earlier first cycles. Then how the therapy of CRC evolved. So it is if patient has NTRK or RET fusion, so with tumor agnostic marker, we have option of entrectinib, selpercatinib, and the in second line we can give alternative doublet chemo, and third line we can give other drug. So for RAS mutant patient, we have option of FOLFIRI or FOLFOX plus BEV. For BRAF mutant, we have option of chemo plus BEV. Second line, third line, encorafenib, cetuximab. Now with breakwater trial, we have option of encorafenib, cetuximab in first line also. Then regarding the CRC with RAS wild type and BRAF wild type, Folfox BEV is for right-sided, because we know that right versus left is a big debate, and right-sided EGFR inhibitor works poorly. For left-sided, standard is Folfox or Folfiri with cetuximab or panitumab. HER2, it will be chemo plus BEV, and second line or third line, like we have now more trial which we will discuss in regarding HER2 or TDXD. MSI high, pembrolizumab is first line too. Then how the therapy evolved. In 1950, we have only 5-FU capecitabine, iron and oxali. For next 50 years, we don't have much of drug. Then came in 2004 bevacizumab, then cetuximab and panitumab. So from cytotoxic, we move to biologic. So from biologic, we have other option of targeted and immunotherapy also. So these are the various options which we have over the period. Then many tablets have also come. So now we combine cytotoxic with biologic agent, and Folfox is equal to Folfiri for most patient. We do not combine bevacizumab with anti-EGFR therapy. Then regarding the therapy, so this right versus left sidedness, it is very important factor, because right sided standard should be doublet or triplet chemo with bevacizumab, and for left sided it should, if patient is RAS wild type or BRAF wild type and non HER2, then treatment of choice is doublet chemo plus cetuximab or panitumab. And for left-sided with RAS mutant, it is doublet plus BEV. For high tumor burden, triplet plus BEV is the option, and MSI high immunotherapy we can give. So KRAS is a molecule. In our practice, we have seen that this KRAS G12C patient, they do very poorly. So this has leads to various newer molecules which have changed the practice, and slowly they will improve the practice more. Then in CRC, what influences our practice? It is comorbidity of patient, prior therapy, performance status, age, then tumor characteristics like tumor burden, resectability, tumor location. Then the what first line, second line, over the period, you can see in this chart that as the line increases, number of patient dropped out. So it is a aggressive disease. Molecular characteristic like RAS, then BRAF, MSI, HER2, and many new molecules are coming, biomarkers are coming, which are helping us to decide the accurate drug for our patient. And performance and everything matters. So this is the guideline which shows that for RAS mutation patient, it should be chemo plus anti-VEGF. So we have 4 line of option. TAS like Tipanet plus or regorafenib with bevacizumab has also shown good benefit. For RAS wild type patient, left-sided, there is only low role of chemo plus anti-EGFR therapy. So the choice of second line therapy depends upon what chemo patient has received in first line. If he has received first line irinotecan, then it should be oxaliplatin based therapy. So where we place bevacizumab in our therapy, like there are many factors like duration of VEGF inhibition matters from treatment to progression, then maintenance strategies, then there is data to support treatment beyond progression. And we have seen that there is synergism between 5FU and bevacizumab. That's why we try to continue this combination. And we have the trial which has supported us that this bevacizumab has shown benefit beyond progression also. And even in TRIBE trial, folfoxiri, we can give triplet with bevacizumab for patient with high burden disease. So this was the design where folfoxiri plus bevacizumab has shown benefit compared to folfiri plus bev in high volume patients. So it has shown survival benefit also, and it is now recommended for patient with high volume disease. Then exit trial has shown that even with capecitabine, we can combine bev and patient can have survival benefit. And irono plus bev is also an option for many of patients. Then there comes data of Tipanet like a task with bevacizumab. So this is also good second or third line option for most of our patients, and they do well. And now we are more merged with management of Tipanet toxicity. Sunlight trial has already shown the benefit of Tipanet with bevacizumab compared to only Tipanet tablet. And here also it has shown survival benefit. So in metastatic patient, in third line, Tipanet plus Bev has longer survival compared to Tipanet alone. So then there comes one more entity of mismatch repair deficit, MSI high patient. They comprises 5 to 10%. Most are Lynch syndrome. We have like 5 to patient with Lynch syndrome now. So there is a benefit of immune checkpoint inhibitor, and there also there is a new data that even with MSI stable patient also, this is early study phase 2 trial, but capecitabine bevacizumab plus pembro has also shown some benefit. It will be checked in a more bigger trial for this using immunotherapy in stable MSI stable patient. So then regarding the other drug which we use post progression on cetuximab is panitumab, because in contrast to cetuximab, panitumab has shown that patient with refractory disease also this drug has some benefit, and even with it can be used for some of selected patients, and it is alternative for patients who have progressed or experienced failure with standard therapy including cetuximab, though this we don't generally practice in our standard. So then then there is a also uh, use of cetuximab, uh, like we don't have a trial of continuation of cetuximab in patient after progression, but we have data for bevacizumab in progression. Then what the NCCN says? NCCN says that we have option of FOLFIRI plus Bev, then Bev, then cetuximab, panitumab with chemo, then marker driven. We have many options like NTRK, RET, and various inhibitors we have for our most of patients. So with this, thank you for the opportunity.
Thank you so much, Dr. Yashwant. I would like to share a slide before we move to our next presentation. Our previous session on management of metastatic colorectal cancer post-progression on cetuximab was sponsored by BMC Oncology and Avestin. Thank you so much. Now, we move on to our case-based discussion on colorectal cancer management, which will be again moderated by Dr. Yashwant Kashyap, who is a senior medical oncologist at BALCO Medical Center. I request Dr. Yashwant to take over, and I also request you to introduce our esteemed panelist for the discussion. Over to you, sir.
Thank you, Achal. Thank you everyone for joining on. So with us, I think all of my panelists are there. So Dr. Gaurav Gupta sir, he is a senior consultant radiation oncology in BALCO Medical Center. Dr. Dipanjan Viswas, he is a consultant medical surgical oncology in BALCO Medical Center. Then I hope Dr. Divakar Pandey is there. He is senior consultant surgical oncology in BALCO Medical
Hi,
Center.
Yashwant, I'm here. Hi, hi.
Yes. Then
Yeah.
Dr. Rakesh Mishra, he is a medical oncologist in surgical Sanjeevani Cancer Center. Then Dr. Amit Agarwal, he is a consultant medical oncology in AIMS Raipur. Then I think Dr. Sushil, he is a consultant medical oncology in AOI American Oncology Center Raipur. Then I hope Dr. Sunil Chopade, uh, he is medical oncologist in Jaslok Hospital, Mumbai. Then Dr. Anshul Agarwal, he is a medical oncologist in Surat, Kiran Hospital, Surat. So I hope everyone is there. So with this, we will discuss about something about colorectal cancer. So Achal, my slides are visible to everyone.
Yes, sir, they are visible.
Okay. So today we will discuss about uh, uh, colorectal cancer. So she is a 58-year lady presented with perrectal bleeding with no prior history. She is a fit patient, ECOG 1. She had right side colonic mass, and she was not in obstruction. And biopsy was done, uh, like colonoscopy guided biopsy done, which they say of adenocarcinoma. Lab parameter CA99 was 723, CA 189, other blood parameters were normal. And on CT scan, she had multiple, 3 to 4 liver mets, bilobar, and and largest was 1.5 centimeter there, and SUV was more than or equal to 8%, and there was absence of extrahepatic uptake. And USG guided has again confirmed it is metastatic disease. This is the scan, and before treatment, this was the scan. So my question to Dr. Rakesh. So Dr. Rakesh, in your practice, what all investigation you do?
Dr. Yashwant, as is a metastatic disease, to go with the upfront, here usually we go with the multi-gene panel, which includes the KRAS, NRAS, HRAS also, along with the BRAF mutation and HER2 and MSI high. So this is the standard panel which we usually recommend in all metastatic colorectal patients nowadays, sir.
Dr. Amit, you are able to send all this for your patients?
Not, sir, not in every patient, but I would prefer to do all these tests, including anti-RK mutations also. So if patient is able to afford, broad gene panel is acceptable, is advisable. But otherwise, this basic test should be done because this can change management.
Dr. Sushil, you are sending broad gene or some fix 5 gene, 6 gene?
Good evening, everyone. So I would prefer multi-gene panel as said by Dr. Rakesh sir, because it is more cost effective than the stepwise mutation panel. But if at all I have to choose, then I would prefer the last option, that is KRAS, NRAS, BRAF, HER2 and MSI high. But practically it's not feasible. So I'm going with the multi-mutational panel.
Yes. So NCCN agrees with everyone. We do all this. So then, because why it is important? Because 5 to 10%.
So, Yashwant sir,
Yes,
I
sir.
have a question to the surgeon here.
Yes, yes.
So, Dr. Diwakar, so what is you are people are okay with the PET scan testing for the metastatic workup in liver only metastatic disease? Do you prefer to go for the MRI?
No. So yes, PET scan is sufficient. MRI has to be done only in case if the lesions are very small, and there's doubt in the PET CT that the lesions are not metastatic. So MRI has a better resolution compared to a PET CT, because the CT part of the PET is actually, the resolution is not good. So if there's a doubt about the lesion or any doubt about the metastasis, then MRI helps. It means that if the PET is not conclusive of metastasis, then probably MRI has to be ordered. That is the only criteria where MRI is required. And other criteria is when you are giving induction chemotherapy, the patient has been planned for liver-directed surgery, be it RFA, be it surgery, and post-induction chemotherapy, if the lesions are not very nicely seen on the PET CT or they have regressed in size and numbers, then probably there also comes the role of MRI, so that we can pick out lesions which probably are not seen on the PET CT.
So, Dr. Diwakar, in another point, actually, if I'm not going for the too much, is any role of fiducial marker placement in case of liver metastasis disease? Because disease might go clean after chemotherapy, neoadjuvant chemotherapy. Then how you will proceed?
So the first thing that we have to do is to plan our management before starting your chemotherapy. So if the patient goes through MDT and we have planned a liver-directed therapy in form of RFA or a surgery, in that case, it is ideal to put a marker. But unfortunately, in real-world situation, it's very difficult to put in many places. If it is superficial, it is easily accessible, then it is okay to place. But it is not like breast. The marker also, if it is very deep, it is quite difficult to place. So yes, if it is feasible, we should ideally place a marker. If it is not feasible, then probably there's no option. We can just pick them on MRI and then see.
And marker is also not available throughout India.
It is, yeah, it is not available.
Also.
That is the biggest problem, that markers are not available.
Gaurav sir, for your planning SBRT, if patient has surgery not feasible, or so, do you need MRI? Or what is it? What it is? You prefer MRI for patient with oligomet liver only lesion, or you are comfortable with PET CT?
I require a triple phase CT scan and a preferable MRI also for my SBRT planning.
Okay. So sending MSI is very important, because 4 to 7% are MSI positive, and we have few patients who are doing very well with advanced disease also in CRC. And as we know that one magic bullet and 12 patients sotorasib. That data was also in colorectal only. So this was so then I will come to this patient underwent outside right-sided hemicolectomy. So then histopathology had showed like uh, like metastatic involvement, and there were uh, 23 nodes were removed and one was positive. So I will ask Dr. Dipanjan, if this patient has not been having multiple liver met, one or two liver met, so what would you have planned? Upfront surgery or chemo first followed by surgery or any other plan? Dr. Divakar?
Yes. So these are to begin with bilobar meds, if I'm not wrong.
Yes, I am asking about another case where patient has only 2-3 lesion.
Yeah. So the problem now is there is no guideline now as to tell that how many lesions are actually deemed unresectable. It is always about the FLR that you talk about. So if the lesions are even bilobar, but if you can safely take them out or do RFA or do SBRT with preserving normal liver, so that can be like offer them curative approach. That is the point number one. Point number two is if we are planning a liver directed therapy, it's better to give them induction chemotherapy and with biologicals. If you like, you guys add biologicals to begin with, that is the approach. After that, it's better that if the patient is able to tolerate surgery, then it is synchronous surgery. Means rectum or right colon with liver can be done in one sitting. If the patient is not able to like withstand that long surgery, or if it is little bigger and it takes time, then probably liver surgery has to be done first, followed by the primary. If the
Dr.
primary is
Anshul,
asymptomatic.
okay. Dr. Anshul, for patient with 2 or 3 liver lesion resectable, what will be your plan? Like anesthesia or liver surgery, then chemo or something like that. Dr. Sunil, okay. Dr. Rakesh, what do you will do?
So actually, it depends upon the risk categorization. So although we do not have the a definite risk categorization, but yes, there's some risk category. Like if there is a not the bilobar disease. So if it is a disease in a single lobe, less than 4 metastasis, so we call it as a low risk disease. No KRAS, no BRAF mutation. So these kind of patient can go for the upfront surgery. But if there is a bilobar mets, more than 4 metastasis, there is a RAS or BRAF mutation positive, or there is a chances of periportal node, then it's better to go with the neoadjuvant chemotherapy first, assess the disease every 2 monthly, and if it becomes resectable, go for the surgery.
Okay. Dr. Sushil, what new adjuvant you will give?
So the treatment depends upon the mutational markers, and if it is RAS-TOF wild type, and since this case is on the right side, so I would prefer either FOLFOX with bevacizumab or FOLFIRI with bevacizumab, but I would prefer mostly FOLFOX with the bevacizumab. And if the patient performance status is good, I would like to prefer the triplet like FOLFOX-IRI with the bevacizumab.
Dr. Amit, what are your plans? Like what therapy you will? Like?
Yes,
So
sir.
it should
So
also
it is a
follow.
right-sided tumor with liver mets. I would prefer systemic therapy first and will reassess the disease status at 2 months. So treatment of choice would be either Folfox or Folfirinox along with bevacizumab. But if I'm planning, I'm hoping that it will resolve and patient might go for surgery in the last cycle before assessment. I would omit bevacizumab.
So Gaurav sir, RFI is better or SBRT has role for
Actually,
where surgery is not possible.
if surgery is not possible, then both have different indications.
Yes.
RFA we can do in 2-3 lesions if it is less than 3 centimeter, if it is not near any vascular structure, because it will lead to heat sink effect. If it is not near the diaphragm. SBRT also, It is preferable when the lesions are less than 3 centimeter or not more than 5 or 6 centimeter, not more than 2 or 3, because we need normal healthy liver at least more than 700 cc to perform a safe SBRT.
I would just like to add on to one point. See, as RFA probably is quite inferior compared to SBRT and surgery. SBRT and surgery are probably sitting in the same level. Both of them provide us a good local control of close to 85 to 90%. And of course, the whatever data we have, the 5-year survival is close to 35 to 50% in select cases in both.
Yeah. And
So
since our
SBRT,
cases, yeah, Dr. Devak, please.
yeah, so SBRT and surgery probably are complementary to each other. RFA has a lot of limitations, as you mentioned by you.
And this, our case is colorectal, and this is also favorable histology for radiation also.
Correct.
Yes, yes. Okay, thank you, sir. So then all these are then regarding sequence, Dr. Divakar has already Dr. Rakesh, there are some guidelines that you can resect the like liver first or colorectal first, then it can be different. Do you prefer this or what you do? You leave everything on surgeons.
No, it depends upon the surgeon actually, what he feel. In a case of the potential resectable disease, it's better to go with the simultaneous surgery if surgeon can feel that patient can go for the simultaneous surgery. Otherwise, in case of unresectable disease, sometimes we go with the uh, surgery for the primary and the metastasis disease later on, depending upon the response in unresectable liver metastasis.
And Dr. Divakar, if patient has like instead of liver met, if patient has colorectal, like hypothetical case, so does it has peritoneal like PCI 8, PCI 9? So
No.
does there is role of HIPEC?
No, so it is a very broad question. So there comes a role of side of the tumor, if it is right or left sided. And unfortunately for colorectal malignancy, CRS and HIPEC is not a proven or very scientific method. So now the latest Cairo 6 trial, which has come with where there's a small subset group of right side cancers where probably HIPEC is going to be beneficial. What does CRS do? CRS probably helps, but again, the data is not very sound, and probably for left side colon cancer, rectal cancer and colon cancer, HIPEC is strict no. For right, yes, in some PCI setting it is possible. CRS helps, but the data is not good.
Thank you. Then like there were some guidelines like you can, if patient has extensive liver mets, then you can remove as many as mats, then you start systemic therapy, then remaining by that time remaining liver will hypertrophy, so then you have option of portal vein embolization, then all this.
Yes.
So
So
what are your
this
comments
is
about this?
so it is done when there's a very high liver burden. So if the patient has very high liver burden, we are giving them Folfox, and which is the oxaliplatin is toxic. So in that way, you can have this approach where you can do a portal vein embolization of the other side, so that you resect that, and then because of that, the liver hypertrophy happens, and then you initiate induction chemotherapy in between. That is done only in select cases where liver burden is high, so that you have a good FLR to resect or do SBRT for rest of the lesions.
Okay, thank you. So this NCCN says that like already if neoadjuvant chemo we have to give, then it should be only for 2-3 months. So Dr. Sushil, what you prefer, Folfiri, Folfox, or Folfoxiri? You have already answered. Neoadjuvant, how many months you give for your patient?
Usually, I give 4 cycles and then do reassessment. So that would be my plan.
If patient is MSI high, then what you will do? If patient with oligomet colon with MSI high, so what neoadjuvant you will give?
So if it is MSI high, I would prefer immunotherapy, pembrolizumab, because that's the guidelines says, and the patient will respond to the immunotherapy.
And
So
if okay, and HER2 positive or BRAF positive, then what will be your choice?
Then if it is BRAF positive, then we can add we can do FOLFOX with bevacizumab because BRAF data is mostly in the second line setting, and also HER2 also similarly it's in the second line setting. So I would again go with the FOLFOX with bevacizumab, and if the patient is fit, then I would prefer triplet with bevacizumab.
Okay, thank you. So, Dr. Amit, so in your practice, what proportion of CRC they are with resectable mets, unresectable, or potentially resectable?
So, sir, resectable liver metastasis, I would say it's usually less than 10%. And majority of them are unresectable multiple mets.
Okay, and potentially,
I mean, sir, it could be again 5-10%, but more than that.
yes. Dr. Divakar, your comments.
Yeah, I
Does how
completely-
many of your patient
I completely agree with Amit actually.
Okay,
So,
okay. So,
and here comes the role of parenchyma preserving surgery, which we are not very well versed with. So that is the other thing it requires. So technically speaking, if the expertise is available, you can take out even more than 10-15 mets also, because there's a concept of R1 here. If it is very close to vessel also, that if that margin also is positive, that is called R1 vessel margin, that is technically considered as a safe surgery, like it is considered as complete surgery. But yes, you need expertise, and because of the expertise, probably the numbers are quite less. If you gain the expertise of ultrasound guided parenchymal preserving surgery, probably the number will also increase.
and in your practice, how many patients after like neoadjuvant you have operated? Like what percentage generally they go
So
for?
it is less than 10, as told by Dr. Amit.
Yes, yes. Okay. So this we have discussed. Dr. Sushil has already answered this. Then chemotherapy, anything. Dr. Rakesh, what are your comments? Chemotherapy.
So, if a young patient good performance status, then FOLFOXIRI is the preferred choice when I'm going with the conversion for the conversion of liver metastasis disease. And if patient already had received the FOLFOX in last preceding 1 year, then I'll go with the FOLFIRI.
And regarding, I have one question. Like if patient has conversion, or like if patient is planned for conversion, so do you decide your therapy based on BRAF and means molecular marker based on other molecular marker like RAS and other, or do you directly start therapy, or do you decide your therapy? Because recently cetuximab data came that cetuximab was not that great. Earlier, it has created lots of hype that chemo plus cetuximab is way to go, but it has not converted in. I think recently completed ULI trial. So, what are your comments? Like,
So, so definitely, the cetuxi with FOLFOX have shown the inferior outcome in case of potentially resectable liver metastasis disease. So the data have now out, and it's better to avoid cetuximab combination in potentially resectable liver metastasis. So there's a two category. One is the resectable and one is the unresectable. So in case of resectable metastasis, it's better to go with the chemotherapy only. Do not add biologics because it adds the toxicity. In case of unresectable metastasis where you need conversion, you can add bevacizumab to get the more response rate. Yes, adding cetuxi sometimes it might work, but the data have shown that it is have shown the inferior outcome.
so this was the FOLFOX series. Like it has, Dr. Sushil already explained that it had shown benefit, and TRIBE trial had shown benefit. So, Dr. Amit, which agent you will prefer for patient for conversion?
So, sir, it is a right-sided tumor. I would prefer adding bevacizumab, but as I told, I would omit this in the last cycle before the so-called plan for surgery.
If let's left-sided tumor, then
So again, I mean, cetuximab data, the as per the data, I would go for either bevacizumab or just the triplet.
thank you. Then this patient was given Folfox plus Bio. Then patient had toxicity. Then the chemo was continued, Bev was continued on same dose. Then after 4 courses, he had no further liver mets, and like he had no residual disease post NSCT and post all therapy. And this was the imaging after NSCT and chemo. Chemo plus Bev, he has responded completely. So this question we have already asked, like what will be the your choice? You all have answered that based on available data. Like then regarding wild type. So this already Dr. Amit has answered that this offers benefit. If it is right side, it will not offer that much benefit. So this was the comment that if patient has right-sided colon cancer, uh, patient should not be treated with cetuximab, and left-sided, either way it can go. Only issue is that RAS mutation. If patient has RAS mutant, then we know that cetuximab is not indicated. Then if patient has Dr. Rakesh, if patient has after surgery and everything R like R0 like pathological CR, then what you do? Such patient, you give maintenance, no maintenance, or what you do? This patient has received 4 cycle Folfox plus Bev. So what you will give?
So in a patient with whom the metastaectomy is already done. So
Yes.
if it is already done, then I'll not go with the maintenance one. Yes, I do try to complete the total schedule of the chemotherapy. Suppose I have given the 2 months of neoadjuvant, then I'll complete the 4 months of total 6 months. I'll try to complete the adjuvant chemotherapy, but definitely I'll not go for the maintenance if the resection of both primary and the metastasis has been done.
Dr. Sushil, your thoughts?
So I agree with Rakesh sir, because if the patient is already underwent resection, we can continue with the completion of the therapy. But here we need to, I want to highlight few points. Like first thing is maintenance post therapy. If the patient is having either a complete response or partial response or stable disease, then we can go with the 5FU with bevacizumab, and it has shown PFS benefit, and even inpatient data IPD analysis also has shown that there is a PFS benefit, there is no OS benefit. And also we need to explain to the patient that observation is still an alternative approach. So we cannot rule out that we have to give the patient that observation is an alternative option.
Dr. Amit, your thoughts? What do you say?
I agree with Dr. Rakesh. If complete resection has been done, just we have to complete the 6 months of the perioperative chemotherapy, and no maintenance is required. But if yes, margin was positive, then obviously we need to give maintenance.
So this was Dr. Dr. Sushil has already explained this, that it has shown some benefit, but not for such patients were not included in this trial. Okay. So now this patient has completed documented pathological CR, and after all this time he is disease free. So uh, Dr. Amit, if this patient progresses after 3 years of post therapy, so what you will do in second line treatment?
So after 3 years, so there's a good disease-free survival. So I would see whether at this point of time disease is suppose solitary metastasis, whether it is going to help by surgery. If not, and it is a metastatic disease, then I would start on chemotherapy, doublet chemotherapy, along with biologicals. That will be bevacizumab. But again, here comes the role of any other mutation which was earlier tested, and if that was positive, that has also been taken into account.
Dr. Rakesh, how comfortable you are with using cetuximab in right-sided tumor?
So, sir, for the right-sided tumor, it's better to use bevacizumab in the first line setting. yes, cetuximab can be added in the second or the third line setting. So it's not a contraindicated, but yes, it does not work. So if better to use bevacizumab if you are using the biologic, and cetuximab can be added in the second and third line setting.
Dr. Sushil, over cetuximab and panitumab, what are your what do you think? They are same or they are different? Because I have shown in that even in cetuximab refractory also, so few patients responded with panitumab.
Yes, it's difficult to tell, but I think cetuximab has got more data compared to the panitumumab.
So I might have here different of opinion that in cetuximab progressive disease, usually panitumumab does not work. There is a again there is a concept of uh, if you break cetuximab for some times, whatever reason, if there is a progression on cetuximab, you treat with another chemotherapy, you stop cetuximab. There is a data that it in the after 3 to 4 months you can again use cetuximab. So it is because mainly because the cells they again become sensitive to cetuximab. So if you are want to use cetuxi after a break of 3 to 4 months, you can again try cetuxi in with combination of other regimen.
Dr. Amit, do you re-biopsy the patient who, for this patient? Like in baseline, I think he was a wild type. So you will re-biopsy or you will go ahead same?
Sir, so there is a almost 3 years of gap. So I would definitely re-biopsy. Although molecular thing, I would not repeat if the biology is showing that it is of colorectal primary. But I will re-biopsy to confirm recurrence.
And what about RAS status, RAS, HER2 and other status, like MSI status? You will repeat or you will not repeat?
That I won't repeat. And anyways, here, since it was a right-sided tumor, I won't be very keen to use cetuximab or panitumumab. So I won't repeat that.
Dr. Sushil, you will do molecular test or not?
I won't prefer molecular testing because in this case, at least if the patient is progressed on bevacizumab and post 3 years, if the patient comes to me, I would continue with the switch of the chemotherapy along with the bevacizumab. So that would be my choice of therapy.
Dr. Rakesh?
So definitely, sir, I'll also not go with the repeat NGS testing because it have not shown the some worth outcome. So it's better to, yes, I do prefer to get the biopsy just to reconfirmation of the disease, but mostly do not go for the repeat NGS testing.
Like in baseline slides, you would have seen that I have shown that there are NTRK, then BRAF. Now we have breakwater and many trials. Many trials have shown like encorafenib plus cetuxi. So there are many things like patient changing from RAS mutant. Like we have sotorasib, edgarsib, all these options. So that's my. I'm a fan of doing repeat biopsy with molecular testing because that might switch or patient might have MSI positivity over the period. So that might change the scenario to some of it. Yes. So then this all you have already answered. Then this was the like wild type KRAS where uh, so this we have discussed that bevacizumab or cetuximab, which one to use. So so to conclude, it has recommended that every panelist have almost agreed with me that a broad panel multi-gene panel should be done, and MSI testing has benefit many patients. Then if patient has very aggressive like a fit patient with a high burden disease, then better to give folfoxiri plus bev, and other patient doublet plus bev. Then if right sided, then bev offers better OS. And there is in metastatic settings, uh, fully metastatic setting, there is role of 5FU plus bev. And there is also after first progression with bev plus chemo, there is a now guideline to support that bev with chemo can be continued. Yes, with this Thank you. Anyone, any other comments, expert comments? Anyone, please. Dr. Rakesh.
So, Malik, my question to the surgeon.
Okay.
Suppose in a resectable or unresectable liver metastasis giving chemotherapy, if you do see disappearance of all liver metastatic disease in PET scan, do you people go for the liver metastectomy in that setting?
No, in that case, I'll repeat an MRI first. If the MRI also shows no disease, then there's no role of metastectomy.
Okay.
And marker side, if already we have put fiducial marker, then what you will do?
Even then, there's no. Then probably there comes a role of SBRT, because if there's no disease on MRI, it's very unlikely that disease is there. Even if you resect it, most likely there will not be any disease. But in those patients, I feel SBRT is one option that can be explored.
So one thing actually, I think we actually also need
But that
to
is my
look out.
personal opinion. There's no data to support it.
So what about the liver toxicity? How you see the liver when we give the chemotherapy? Because both oxaliplatin and irinotecan are the hepatotoxic drug. Giving more than 3 months ultimately lead to the liver toxicity.
Correct.
So when you operate,
So because of that, we usually, if the patient is planned for liver-directed surgery, ideal time is between 2 to 3 months. If we delay it because of any reason, then in that case, you cannot take out a large part of the liver. The FLR that is required is ideally 30%, but in those situations, probably need little more FLR. So surgery is very challenging.
So is there anything which you do to check how much liver toxicity already had been the chemotherapy has been damaged the liver?
No, there's no way. There's no way to know that.
Okay.
Gaurav sir, I think you were there. Gaurav sir, when you place radiotherapy?
When there is
where after first, we started with chemo, then before next cycle or something in between, or fiducial marker, or how you place SBRT?
actually ideally we should put a fiducial marker and we should complete the chemotherapy. If at all it is not possible to complete chemotherapy or it is not resectable, then we can incorporate SBRT, means in between.
So, sir, question to sir, what is the volume which you treat? It is the
700
pre-chemotherapy
cc.
or post-chemotherapy?
No, it will be actually the pre-chemotherapy volume.
Okay.
We will fuse the initial CT scan, triple phase CT scan with our planning CT scan, and then we will treat it.
Okay.
Sir, we have one patient recently, 2023 operated everything. Then he had liver only met. So we were very worried. Like surgeons were somewhat afraid at that time about surgery. So we have given SBRT. So after SBRT, after 6 months, 8 months, he progressed again in liver only. So now he is operated. So is it very difficult to operate post chemo, with post SBRT recurrences and other? I just want to.
Actually, if the location is different, then it is not going to be that difficult, I guess. But if it is recurrence over the same site, it's still basically SBRT is very precise and very focused, and very little volume is getting irradiated.
So we're talking about re-radiation, or we're talking about surgery?
Surgery. He's talking about surgery.
Post SBRT surgeries will not be a problem.
So it is not going to be a problem.
Yes.
Because patient has already received multiple line of capox and all, and he has received liver. Like in lung, we were many a time worried about lung toxicity. So similarly, like patient post oxaliplatin, post SBRT. So does surgery?
Liver tolerates SBRT pretty well. Means basically when I was in Rajiv Gandhi, I had not seen any patient with RILD or any radiation-induced liver damage. And I guess with surgery also, because mets are small and limited, they can be excised post SBRT and post chemo also. I think Dr. Devakar will tell.
Sir, so most culprit is, sir, here is the chemotherapy, sir. So yes, it is very bad. Actually,
So
chemotherapy
how do you
induce.
assess liver damage caused by chemotherapy means? Because we have only one tool, child book criteria, and we can just calculate the volume of normal liver
So,
after deducting the gross diseases of metastasis,
sir,
volume of that. So that's it, basic two things. So how
it's
do you assess liver damage with chemotherapy?
so it depend upon the two things, which agents which you are using. So
Okay,
oxaliplatin is usually causes the sinusoidal damage, and the irinotecan causes stenosis. So
okay.
what happened? The sinusoidal damage ultimately lead to the portal hypertension, and that lead to the splenomegaly. So suppose
Mm-hmm.
in a chemotherapy patient, if you are seeing in the imaging that there is a splenomegaly which is ongoing, it means
Mm-hmm.
patient is developing the oxaliplatin induced toxicity. So yes, you keep and watch on these things which
Rakesh,
actually sometimes.
sorry to interrupt. I think I would like to differ. Splenomegaly is very last, like it is the very like if you stage it, it will be appearing very
Maybe
last. So it is
it's a finding
splenomegaly
which we can find in many normal individuals also.
Many normal
there
images.
also,
It's
and
not.
here if splenomegaly has happened, it means it is already very late stage.
Yes, I do
Is
agree.
there
I
any way
do
to?
agree. I do agree. There is a MRI which is called the supramagnetic. That is that MRI which actually can assess the sinusoidal injury to the liver. But I don't think this
Okay.
MRI is available here. But yes, there is some clinical findings where which you can see that yes, there is already liver damage which is already happening. If you see
So
splenomegaly.
other options are the functional scans, the HIDA scan and all, where the liver function basically it is a functional scan of liver. So there's a cholestatic. So that is other area where that is other test that they can pick up whether there's liver is going in cholestatic phase or not.
Because actually liver damage is a very concern because almost 50% patient will have the liver damage if they already had received the chemotherapy.
I think Dr. Yashwant is talking about the patient operated last month who
Yes,
was
yes,
having
yes,
who was having two liver lesions
yes,
and
yes,
SBRT has been given.
yes,
So
yes, yes,
intraoperatively there was no difficulty. I mean, it was uh, simple procedure, and he recovered very well in post-op period.
yes, yes.
So
And we have planned for close observation for him because he
yes,
has
yes,
already completed therapy and he is like disease free. Yes,
yes, yes.
yes, yes.
And one more patient, rectal primary with axillary mets, we operated last month. There was only one axillary met.
Okay.
If you
Axillary
remember.
nodal metastasis.
Yes, yes.
Okay.
So it was M1. She was undergoing palliative chemotherapy. Then we removed. Then she is on observation now.
Okay.
For Dr. Rakesh, regarding your question, like we are in close contact with gastro because apart from auxiliary, many things are going on to our patient, and many patient has HCV reactivation. My one patient after 2 cycle develop deranged LFT. So I have now seen that HCV titer, repeat HCV titer, baseline was negative. After it reactivated, so gastro opinion, close follow-up, all these are very much important for such patient. Yes. So,
Sir,
Yes.
sir, there is one. I have two questions for you, Yashwant sir.
yes.
Uh, After SBRT, suppose patient has not completed his chemotherapy. After SBRT, how much we should wait before commencing on the next cycle of chemotherapy?
Like Gaurav sir already said that tolerance is very good for liver. So few patient in oligomet, breast and other we have started. We are not waiting much. Unlike bone marrow radiation and other, we are not waiting. Gaurav
Means
sir, you
10
agree
to
now
20
that
to, yeah,
uh,
10 to 14 days, maybe 2 weeks gap is good enough.
Okay, sir.
yes,
So,
Yes.
sir,
And and
I have a something which actually I want to put a point to add. Actually, I do not know the data regarding the uh, SBRT and chemotherapy timing interval. But yes, definitely for the
Actually,
surgery there is a data.
for, yeah,
You have to
actually,
wait at least 4 weeks
no,
after
no, no, no.
chemotherapy.
Actually, UK consortium guidelines is there for SBRT. They have mentioned 2 weeks gap between SBRT and other modalities. It's a safe thing. I agree there is no data, but guidelines are there which have mentioned. So we are following that, and we are also seeing means patients are tolerating well.
But for the surgery,
For the
my question is
surgery,
to the surgeon. Suppose how much time you actually wait for the chemotherapy
So wait, I
after?
really wait for after 2 weeks of chemotherapy. Patient is mostly fit by second and third week.
Okay.
Yeah, but again, if the patient is also receiving bevacizumab, we need at least 6 weeks minimum before we stop bevacizumab for the patient to come to table. So for that, we have to stop it one cycle before, and then maybe the last cycle we have to omit the bevacizumab and then take after 2 to 3 weeks of that.
Amit,
Means
I hope
LFT
we
is
are clear.
normal
Yes,
and
yes, Dr. Dipendran, continue. Okay.
yes. If LFT is normal and patient is tolerating well, then we can start up to 2-3 weeks. It's okay, we can do. And FLR, obviously, if you have to see the FLR, that is very important. If FLR is okay, we can go ahead with surgery.
Dr. Amit, your other question. You are asking two
Sir,
questions.
so are you doing TMB as well, tumor mutation burden?
Like in many affordable patients, like corporate patients, we are sending. So because though not taking much decision based on that, but sending because over the period and with Dr. Rakesh and others, I think all this help because I have seen that concomitant mutations and sending a broader panel with TNB many a time it helps for guiding. Dr. Rakesh, you are doing TMB?
So actually, very interesting point, sir. Actually, I'm doing TMB, but the problem with the TMB is that lot of time the somatic mutation ultimately lead to the a false reading of high TMB. So recently, one I during interaction with one of the genetics person, she told me that if you want to rely TMB, it's better to do with go with the both tumor and the liquid biopsy both. Then only you are able to get that whether these are the something which are coming with the somatic mutation or the germline mutations.
I have a question mainly to the medical oncologist. Suppose if the patient has come and then upfront we have done mutation testing and it's RAS-ROF wild type, there is no mutation, and we have given the therapy. Like suppose, like in this case, we have given Folfox with the bevacizumab, and then the patient underwent surgery, and then and then the patient has progressed after 2 years or 3 years. How likely that we are able to find a newer mutation? Like if the patient is not upfront HER2 positive, how likely are we able to find in on progression? Like is it a possible scenario, or how what it is?
So, Dr. Sushil, as per of my experience, actually, in the colorectal cancer, you do not get the changes in the KRAS, NRAS, and whatever the common mutation is there. You usually do not get the change in the pattern, like we see in the lung cancer.
Mhm.
Okay, so yes, definitely for the these common mutation, they usually do not change after the treatment. But yes, you might get some very uncommon things which were not there, like the NTRK, ALK nowadays, because we have a lot of targets for these agents. So definitely in a patient who is affordable, it is better to understand what the genetic changes which is ongoing on the patient tumor. But for the therapeutic purpose, usually it does not give you too much newer things.
So, if suppose the patient is not having any NTRK mutation upfront, the patient has progressed and we have repeated. Is it a possible scenario that the patient can have NTRK mutation in the recurrent setting, or it's not like that? Is my doubt.
Clinical experience, no. But
Okay.
you need to understand that the first biopsy sample you have underwent all NGS testing, because most of the time usually you go with the targeted colorectal panel, so you do not
Yes.
test every alternative options.
Yes,
Okay,
and now we have drug like sotorasib and other, which are KRAS 12C inhibitor also. and so Edgar Sib and other. So we have option. So as Dr. Rakesh is saying, I think Dr. Sushil, that gives us a key to rebiopsy sometime.
Yeah, I have a question for all
Baseline
medical
panel is not.
oncologists.
Yes.
Yeah, so if the patient was metastatic to begin with, and then patient received liver-directed therapy, and patient is declared cured, you have given 6-month chemotherapy, and then you're stopping, then you're not giving drug. Is there any role of ctDNA in such patients? Is there any data to support testing ctDNA and at least identifying some patients where probably ctDNA is positive, you might start something?
Dr. Sushil, what are your thoughts regarding
So
ctDNA?
mainly the role of ctDNA is there in the stage 2 colon cancer. In the metastatic setting, I think ctDNA will be there. It will be positive because the micromets are there everywhere. So I don't think there is role of any ctDNA in metastatic setting for routine, but ctDNA is useful in identifying mutations in the metastatic setting. So that is the role in metastatic setting.
Yeah, so
In
I'm
the
talking about patient who is declared cured, kind of. So we had one patient just which we operated after 3 years. He developed a new met after 3 years, which was resected recently. I'm talking about such patients. Is there any protocol where we can integrate ctDNA as a follow-up test so that we can pick up those patients who are going to recur early, and
Yeah,
maybe we can start them on systemic
yes,
therapy early?
Yes, Dr. Divakar, like Dr. Sushil said, for stage 2 and other, ctDNA is already proven. In recent ESCO 2025, there is, I'm not exactly remembering, but there is a one study which has shown that patient who are positive in follow-up, like oligomet patient, they do bad. So their chances of relapses are more. So hopefully in few years, we will be doing ctDNA for all such kind of patients, which Dr. Dipanjan and you are talking. Yes. So I think yes,
A
yes.
basic question to medical oncologist. What is the difference in systemic therapy in palliative setting in rectum and colon, or we treat as left colon as rectum?
So there's no much difference actually when you see. So almost only thing is the difference is comes the radiation role of radiation. So in the rectal cancer, there is a role of radiation. In the colon cancer, there is no role
No,
of radiation.
I'm talking about palliative setting.
In the palliative setting, also there is a role of radiation in the rectal cancer because it helps in the bleeding and obstruction. Radiation have role. Usually, I do prefer at least short fraction of radiation, even in the metastatic disease, because it have shown very good local control if using short fraction artery like 25/5.
Yeah, Rakesh, I have a question for you. So in all patients, you're giving short course radiation because there's no guideline to support it.
It depends upon
Metastatic.
the it depends
I
upon the
agree
there
with
is obstruction
bleeding
symptoms or
patient.
bleeding symptoms or not, because
Yeah, I agree. If the patient has bleeding, then it's like a hemostatic RT. There also
yes, that's
25 gray is too high.
that's
25 gray probably is very high for it's a curative dose for rectum.
no,
So do
no.
you treat these
25 into
patients?
5 is a palliative dose.
20 in
25
5
and
is a
5 is a
palliative
curative
dose,
dose for short course
30 in 10
rectum.
is a palliative dose, but we can give 25 in 5 as a palliative means setting
Yes, I
because
agree. My
means
only
it's
question
just a
is,
pragmatic approach.
Yes. So
it
I
that
think
much dose is
Achal,
required to stop bleeding?
Yeah.
so with this, I think already we are at 10. So Achal, can you take mic from here? So with this, I thank my all panelists. Thank you, Dr. Sushil, Dr. Amit, Dr. Rakesh, Dr.
Thank you,
Dipanjan.
Dr.
Thank you, everyone.
Yes. Achal, please
Thank you.
conclude.
Sure, sir. Thank you so much. Thank you, Dr. Yashwant, and our esteemed panelist for today's discussion. With this, we come to the end of today's session.
And I want to thank Cipla and other partners for giving us opportunity. And thank you, Bhavna ma'am and BALCO Medical Center for organizing such a, yes.
Of course, sir. Thank you, our academic partner, Cipla, for making such discussions possible. Thank you so much, everyone. Looking forward to hosting you to our future BALCO Medical Center Oncology webinar. Good night.